You're listening to Health Coach Conversations, a podcast where our conversations help health coaches all around the world to level up our businesses and to get more clients.
Hi, I am with Dr. Howard Schubiner today. He's an internist and clinical professor at the Michigan State University College of Human Medicine and has authored more than 100 publications in scientific journals and books. He lectures regionally, nationally, and internationally and is the author of 3 books, Unlearn Your Pain, Unlearn Your Anxiety and Depression, and Hidden from View, written with Dr. Alan Abbas. Dr. Schubiner has worked with Dr. Mark Lumley to develop a novel psychological treatment for chronic pain, emotion awareness and expression therapy, which has been shown to be highly effective in randomized controlled trials. Dr. Schubiner sees patients virtually from anywhere in the world and at his website, and he lives in the Detroit area with his wife of 40 years. They have 2 adult children. Our topic today is going to be on chronic pain. Okay, so I'm really happy to have you here today. I love this topic, pain and chronic pain. And you have the book, Unlearn Your Pain. What do you mean by that?
I do. It's a title that just hit me one day, and it really incorporates a lot of our modern understanding of what pain is in the first place. Most people would assume that all pain is due to some structural damage in the body. That's the model that René Descartes figured out a long, long time ago, and it's the model that we've been using all these years. Mm-hmm. And the modern modifications of that model, back in the 60s from Melzack and Wall, had to do with the idea that there's a gate theory and that pain can be modified by the spinal cord and can be modified by the brain. And so modern chronic pain treatment tends to revolve around the idea that chronic pain can be managed and coped with better, but cannot usually be cured. That's kind of where the field of chronic pain is in and has been in for a long time. And that's when I started doing this work 23 years ago now. That's what I found when you go into the field of chronic pain. So when we backtrack to say, well, what is pain? We've learned in the last couple decades from neuroscience that the brain works by something called predictive processing. So it's a little bit of a detour here into how the brain works. And what I say to all my patients is, you can't understand pain unless you understand how the brain works. So, and predictive processing, this model of how the brain works, has not really filtered into medicine or modern psychology for the most part. So predictive processing means, in brief, that our brain creates what we experience. Okay, that sounds woo-woo. It doesn't sound neuroscience. It sounds like, oh, this is a new age thing, right? No, but the hard neuroscience is the brain actually creates what we see, because we don't see with our eyes. Light comes in our eyes. It gets transformed into neural impulses, and the circuits go back to the visual cortex, and the visual cortex creates the images that we see. And sometimes the images that we see are not what is actually out there in the world. Our brain has ways of transforming them and changing them. People who have seen a criminal, who have seen a crime being committed, then they go to the police station, they pick out the person, they're often wrong. What they think they saw is not what they actually saw. And so when you think about the fact that our brain creates what we see and what we hear, it also creates what we feel. Now, this is revolutionary. And the simple way we know that is millions of people have had injuries and had no pain. Think about it. If you have an injury, a friend of mine shot a nail in his hand at a construction site by mistake. He had absolutely no pain until he got to the hospital. How could that be? It's the only explanation has to be that the brain decides whether pain is turned on or not. His brain didn't turn on pain. An injury sends signals to the brain, but the brain decides whether pain will actually occur or not. Pain is a brain-generated phenomenon. That's what pain is, and that is mind-boggling. So the first fact. The second fact is that pain can occur in the absence of a physical injury. Okay, how do we know that? Well, simply, there's the story we always tell is the guy in Britain who had a nail all the way through his boot. He jumped at a construction site. The nail was sticking all the way through his boot, right? And he had severe pain, screaming in pain. They gave him IV medications for pain when he got to the emergency room. And when they took his boot off, there was no injury at all. And research shows that stress and emotions activate the exact same parts of the brain as does a physical injury. So the pain is real. All pain is real. All pain is generated by the brain. So when I say unlearn your pain, we're saying that neural circuits in the brain can be the cause of pain, either in the presence of physical injury or in the absence of physical injury. And that pain can be unlearned when there's no physical injury to account for the pain, which we can talk more about how we figure that out. But that's the basis of this idea of unlearn your pain.
Well, okay, so if your brain is what decides you're feeling pain, is there something that you can do that even if there's a physical reason for it, that you wouldn't feel pain?
Well, a lot of people ask that question all the time, right? It's like, well, can you control your brain and tell it, in essence, or have techniques to turn off pain when there's a physical injury? And the answer is generally no. I mean, Buddhist meditators, maybe, deep level, high level Buddhist meditators, maybe, but the processes we're talking about are subconscious. They're not conscious. It's not you're consciously deciding whether to have pain or not. If you could consciously decide that, you wouldn't have pain even when you have a nail in your hand. But 99% of the time when you have a nail in your hand, you're going to have pain because the brain is there to protect you. The brain's subconscious processes, this danger signal in the brain, or the neuroscientists call it a salience network, is there to protect us. If you break an ankle, you want pain because you want to know not to walk on that ankle. And children who are born without the ability to feel pain often have a lot of injuries and may die at an early age because pain is a protective mechanism. Mm-hmm. So we need pain as a warning. What we've found is that pain can be a warning, and this is revolutionary. Pain can be a warning of an emotional process. Pain can be a warning of something that the danger signal picks up as being threatening in one's life. And this is something that has not generally known in medicine and mental health fields and physical therapy fields and nutrition fields.
If somebody suffered from migraines,
yeah,
could you get a migraine just because you expected to get a migraine? Because you know that this is the time that you get migraines, or?
Well, again, it's the answer is yes, and the answer is nuanced because it's a subconscious process. It's not consciously you're saying, oh, I'm going to get a migraine, although you might, because if it happens every time you have a menstrual period, or every time you drink red wine, or every time you have chocolate, or the weather changes, these are all triggers. And migraine is well known to have so many triggers. Mm-hmm. And we would think of these as conditioned responses, associative learning. The brain has learned to produce the migraine attack in response to the triggering event. And one of the things that we do is we help people unlearn those triggers. And there's very specific techniques for doing that. Because if you don't unlearn the triggers, sometimes what happens is the triggers multiply. Mm-hmm. And they get worse over time because the more you avoid snakes and even thinking about snakes, the more you avoid heights and other things which are phobias, which trigger anxiety, the more power they have over you.
So could you be hypnotized not to feel pain?
You can be hypnotized to reverse neural circuit pain, or what I would call neuroplastic pain, certainly, because what our treatment model is to change the neural circuits in the brain. And there's many ways to change neural circuits in the brain. We have specific methods that we can discuss, our treatment models that we use, but there's lots of other treatment models, including hypnosis, including nowadays people are using psychedelic-assisted therapies, biofeedback. There's a lot of ways to train the brain and rewire neural circuits in the brain. Yeah, absolutely. And this kind of gets into the power of the placebo effect. I was just talking an hour ago to a friend of mine, and I was telling her about a friend of mine who's a psychologist. And you're talking about migraines. And so in the early 80s, he was doing treatment and research on biofeedback for migraine. And at that time, the biofeedback machines were very big and bulky. I mean, it was like a whole table full of machinery to measure your temperature in your finger, basically, and whatever they were measuring, and or EEG as well. I think maybe they were using. So they had people hooked up to this big contraption, and they were finding fantastic results with using biofeedback for migraine. And then over time, the machinery got way more sophisticated, and they had a little handheld device. So now instead of a whole table of machinery, they had a little handheld device. That was your biofeedback machine. And he was saying, like, our treatment used to work better. And he was interested in that. And so he did a little experiment. He got out the old equipment. Mm-hmm. He reinstated the old equipment that took the whole table, and he started treating people with that again. He said the results got better. And this is a subconscious response of how the brain responds. And what we're doing to a significant degree is harnessing the power of the placebo, harnessing the power of the neurochemistry. It's real. This pain is real. It's not imaginary. It's not fake. It's not all in people's heads. It's not purely psychological that they're damaged or broken or demented or weak. It's not their fault. All these things exist in the field of chronic pain where people are blamed.
Yeah, they say it's all in your head.
Horrible. It's so invalidating. And we go to great lengths to help people understand that that's not what we're saying. Even though every time we say it's in your brain, they hear it's in my head. They hear that. And we have to really go to great lengths, like I said, to care for people and be compassionate to people and show them that we care and we know that their suffering is real. And we're offering hope for reversal as opposed to simply coping and managing their chronic headache or back pain or fibromyalgia pain or irritable bowel pain or pelvic pain that is often diagnosed as being incurable because it's a neuralgia or it's an irritable bowel or it's your gut biome or it's your neurotransmitters or it's your genetics or all these ways of explaining it in medical terminology that is accurate but not necessarily causative. And one of the truths of science is correlation is not causation. So if people have chronic back pain and they have bulging discs on their MRI or they have degenerative disc disease on their MRI, they're told 99% of the time that that's the cause of their pain. It's a structural problem. But what they're not told is that people without any pain also have the same degenerative disc disease and the same bulging discs. And the data is very clear. We've known this for decades, that MRIs are abnormal in normal people. The MRI of my neck has 3 levels of bulging discs and neuroforaminal stenosis that theoretically should be causing neck pain and arm pain. And I don't have any of that because it's normative. It's like getting gray hair. As you get older, you get these changes in your spine. So it's it's a revolution in how we think about pain, but it has to be explained in a very nuanced way and a very compassionate way for people to get it.
Well, okay, this is going back to the beginning. How did you figure this out? How do you have scientific research that shows this? And I'm not questioning that you do.
No. You should be.
How you got there.
We should be questioning. That's the whole point of science. If you're not questioning, you're not a scientist. If you're not humble about your work, you're not a scientist. If you think your work is going to cure everybody, you're either lying or delusional.
Yeah.
So let's just get that up front. And I didn't figure this out. This is the idea is that the mind affects the body has been around for a couple thousand years. Ovid, the Roman, poet, said, when the mind is ill at ease, the body suffers. And I learned this work from Dr. Sarno, John Sarno, who was a physiatrist in New York City and NYU. And he wrote these books that literally, his books were curing hundreds of people. They read the book, mostly about back pain, but other of these neuroplastic conditions that I mentioned as well. People would read the book and their pain would go away. And it was like amazing. And they became like devoted to Dr. Sarno. You cured me. And what did he do? He explained the mind-body connection. He explained what I was saying about back pain. He explained that stress and emotions can cause real physical pain. And people, not everybody who reads the book got cured, but enough that it became a term, the book cure. So I learned about this from him. And we've refined this process over the last 22 years, and not just me, obviously, but lots of other colleagues that I have around the country and around the world who've been doing this work. And we've published randomized controlled trials. So a lot of treatments have outcome data. For example, there's a treatment called coccygectomy. If someone has chronic tailbone pain, surgeons can remove their tailbone, remove their coccyx. This seems incredibly barbaric and invasive and risky to me and to anybody who thinks about it, because they're removing normal tailbones. There's no disease in the tailbone. They were treating pain with surgery. But if you look at the outcome data for this, it's got super positive results, just outcome data where it's not controlled. It's not a randomized controlled trials. And so outcome data can be really good because of the power of the placebo effect. Blue pills work better than red pills. Injections work better than pills. Surgery works better than injections. Pain is a subjective phenomenon, and a really good placebo can be all you need. So we've got randomized controlled trials. And I don't know if you want to, I can send you links to those, but we've got two basic, our treatment model, let me just back up. Our treatment model is to assess people to make sure their pain is not structural. We don't treat structural pain. Structural pain is treated by medical disorders. If you need surgery for your back, you should get it. If you need anti-inflammatories for rheumatoid arthritis, you should get it. So that's the first step in the model. The second step is explaining the whole neuroscience that we talked about, predictive processing and how the brain works. And then we have these basically three treatment models. One is we call pain reprocessing therapy, which is how to change the neural circuits in the brain, which you can do, like I said, by things like biofeedback, hypnosis. We have our own method. The second is emotional awareness and expression therapy, which is dealing with the underlying emotions and traumatic events in people's lives to help unravel those and process those. And the third approach is to help people make a change in their life. Sometimes you actually need to make a change in your life. If you're stuck in a relationship or in a job which is so demeaning or debasing or belittling or abusive, you literally may need to change that in order for the pain to go away. And we've seen this, so many times. But we have randomized controlled trials for the pain reprocessing therapy. We have the Boulder back pain study, which showed that 3/4 of the people who were randomized to our arm of the study became pain-free in 1 month with chronic back pain. Average duration of back pain, 10 years. That's amazing. Not just coping, not just pain going down by 1 or 2 points on a visual scale of pain, a 10-point Likert type scale of pain, but literally going away. And, the standard psychological treatments for pain tend to have a 0.5 point mean reduction in pain. That's the standard for the standard psychological therapies. And these are good psychological therapies, but they're not using the advanced, what we would call the advanced or modern science of the brain and unlearning pain. And then the emotional awareness and expression therapy also have randomized controlled trials showing that it's more effective in reducing pain than cognitive behavioral therapy, one of the standard treatment approaches.
Turn your expertise into a thriving practice with the Health Coach Group. We provide the support and resources you need to succeed. Your passion, our expertise. Together, we can make a difference. Visit thehealthcoachgroup.com today.
In your book, you talk about what I would call lifestyle management, which would be like journaling about your feelings for pain. This is great because our listeners here, this is what they do. They work with people on things like that. But you talked about that. You talked about cognitive therapy.
Mm-hmm.
Reframing your thoughts. There was a few other things too.
Yeah. Well, we really talk about self-care as well,
Mm-hmm.
because people have a relationship with other people, obviously. They have a relationship with their work and the society, but they also have a relationship with themselves. And a lot of people that we see who are stuck in these chronic neuroplastic pain conditions tend to need a little bit of help in how they take care of themselves and how they honor themselves. They tend to be self-critical. They tend to be self-blaming. They tend to be people who do everything for everybody else but put themselves last. They tend to be people who sometimes don't stand up for themselves and say what they really want or need, or take action to get that in work situation or relationship situations. And that lack of kind of self-care, they don't take time for themselves often. Mm-hmm. That lack of this arena of self-care, in a sense, you could think of it as a lifestyle change, but it can be really critical because the messages that people give themselves can be very negative or can be much more positive. And we found that can make a big difference as one of the components of helping people change the neural circuits in their brain that are causing pain. And the journaling part of it is part of the emotional processing part of things. There's a variety of ways to do that. There's some meditative processes that we also use. So I know a lot of the people that you see and talk with have been trained in meditation practices, mindfulness meditation. I've been a mindfulness meditation teacher since 1999. And it can be an extremely useful component of this work. And what we found that's really interesting is that the studies on the randomized controlled studies comparing mindfulness for chronic pain to cognitive behavioral therapy to chronic pain, or acceptance and commitment therapy for chronic pain, all show the same results. They show small, significant, but relatively small effects on actually lowering pain. They tend to be more effective at helping people cope with pain. Our model is not to help people cope with pain, but it's to help people reverse pain. And it's not always, like I say, we can't claim that every single person is helped, but our data is pretty strong. But nevertheless, what we believe is that mindfulness is really effective for people with thoughts. They said, "Oh, I have this thought. Oh, is that thought real? Is that thought valid, or is it just a thought?" If you can observe your thoughts from a bit of a distance with equanimity, with compassion, you can observe your thoughts, then the thoughts have less power over you. Well, we use mindfulness techniques in our pain reprocessing therapy model, and these mindfulness techniques are more effective in our model than in the strict mindfulness model because we've done the preliminary work of helping people understand that their problem is not a structural one in their body. It's real, but it's not a structural one in their body. And the pain itself is generated by the brain. And it's, in a sense, like a thought. If the pain is like a thought, it can be treated like a thought using these extremely well-tested and well-known mindfulness techniques. And when you use mindfulness techniques for a thought, and if the thought is a sensation in the body, it's just a sensation, wow, what a difference that can make in actually turning off pain. Because when people start to do that, they start observing their pain. They sit and they observe the sensations, and then they start to shift and they start to move. Well, why is it moving? Why is it shifting? Why is it getting better? Why is it getting worse? It's the brain doing that. And when they see that, They say, oh yeah, it is my brain. Holy cow. Look at that.
Mm-hmm.
It is my brain. And then they have more hope, more optimism that they're going to get better. They feel more control over it because when they lower their fear of it, when they lower their hypervigilance over it, when they lower their worry about it, when they lower their frustration about it, and they treat their brain in essence how they want to treat themselves with kindness and caring, that their brain is just trying to protect them from some danger, but they're not actually in danger, and they can correct the neural circuits in the brain, which is called correcting a prediction error in neuroscience terms, the whole neural circuit can change. And we've seen lots of people where one symptom, like the irritable bowel, the stomach pain, and the diarrhea will get better, and then the headaches get worse. Or the fibromyalgia pain gets better and the anxiety comes on. And then they start to see that all these things are neural circuit related. All these things are neuroplastic, and they can all change, and the brain is producing all of them because so many of the people, and I'm sure the people you're addressing here in this podcast, are seeing people who just not that they have one disorder, but they have often many disorders that are all in this category.
Yeah, that's why you get to be 70 years old and you're taking 23 daily prescriptions. Do you see that there's a difference? I see people who are very closed-minded and they get pain and they just know they're going to live with it for the rest of their lives. And there's other people that get pain and they go to physical therapy and, they try stretching at home, or they try, doing whatever it is, or maybe change their diet to reduce inflammation. Do you see a difference? Do you have to work with mindset before you can work with the other?
Yeah, it's super important. Super important. One of the fascinating, I don't know why I'm reminded of this right now, but there's a lot of your folks may have seen this YouTube video from the neurosurgeon who was trained at MIT, and he ended up quitting neurosurgery. He was doing back pain on people. And he's a really heartfelt young man, really smart. And he was operating for chronic back pain on, dozens, hundreds of people. And he found that whether the surgery was done correctly or not, didn't determine if their pain went away or not. It didn't matter. It wasn't that important which disorder they had in their back. Was it a bulging disc or a degenerative disc or whatever? What matters is how they reacted to the surgery. Were they somebody who did their stretching, who did deal with their stress, who did deal with their diet, who kept being active and kept moving and started doing more and had this positive attitude? Those are the people he saw that got better. And the people who didn't get better, the people who were stuck in their lives, stuck in stressful situations, didn't change their relationships, didn't change their lifestyle issues, all those kinds of things. And he was like, well, what am I doing? He had a crisis of the soul. And he quit. He ended up quitting making incredible amount of money doing this, but he couldn't do it. And he quit. And he has this YouTube, it has millions of views. And so it really points to the power of what you're talking about and the fact that a lot, and I hate to say this, but it's true, a lot of back surgery done in the US and around the world is unnecessary. It's unnecessary. We're operating, not all, some back surgery is necessary. If you have an abscess, if you have a tumor, if you have a really huge disc that's absolutely pressing on the nerve and causing neurologic compromise, yeah, surgery can be extremely helpful. But much of the back surgery is done for chronic pain. And the only indications are, one, chronic pain, other treatments haven't worked, and findings on the MRI that are also seen in normal, healthy people. So correlation is not necessarily causation. And it'll work for some people, of course, because the placebo effect of surgery can be very powerful, as I pointed out with the tailbone surgery studies. So it's critical what mindset people are bringing to this. And unfortunately, in the world of chronic pain, as I said before, frequently chronic pain is viewed as incurable. So people are told to never expect to get better, both by their mental health providers and their physician, advisors.
Is there a way to tell whether your pain is actually a physiological pain or if it's something that your brain put there?
Yeah, we've spent a lot of time doing this, and we just published a study in the Journal of Pain where we took 222 consecutive patients with no exclusions, whatever they had, with chronic neck and back pain, coming to a physical medicine and rehab clinic. And the lead authors, a friend of mine, William Lowry, a great physiatrist, and we used our model for diagnosis, which is different than the standard model. The standard model for diagnosis of chronic neck and back pain is take a history, see that the pain is there, see that it's chronic, see that it's severe, look at the MRI, and then correlate the MRI with the pain. Well, if you're 50 years old, there's an 80% chance you're going to have degenerative discs on your spine if you're healthy and normal.
Mm-hmm.
There's a 60% chance you're going to have bulging discs if you're 50 years old. 60% chance of having bulging discs on your spine if you're healthy and have no pain at all. And this goes even higher, obviously, when you get older. But even in 20 and 30-year-olds, there's about a third of 20 and 30-year-olds who have degenerative discs or bulging discs on their MRI with no pain at all. So our model is to first rule out a structural problem. So ruling out a fracture, a tumor, neurologic compromise, something that's obviously serious and something that needs medical attention. So that has to be done. And everybody needs that and deserves that. That's job number one of any physician. The second step, though, is to not overinterpret these common mild, quote, abnormalities on MRIs and look deeper at the characteristics of the pain. So we've developed these criteria that I call the FIT criteria. They're FIT, functional, inconsistent, and triggered. So a functional pain is that it's in a broad area. If it's all over the back or one whole side of the back, that doesn't fit a physiologic, pathologic process. If it goes down both legs in the absence of something in the spine that's causing pain to be in both legs, if the neurologic exam is normal, and if the pain it's spreading over time and it occurs without any injury. And then if it's inconsistent, does it turn on and off? Is it sometimes in the upper part of the back and sometimes in the lower part of the back, or the right or the left? Migraine typically turns on and off. Trigeminal neuralgia turns on and off. Why is it doing that? Structural disease and inflammation, would that be turning on and off? No, not really. That doesn't make sense. If your arm is broken, your pain doesn't go to the other arm. It doesn't turn on and off. I mean, we're just using and then common medical knowledge. And then is it triggered? Is it triggered by chocolate? Is it triggered by red wine? Is it triggered by the wind? Is it triggered by weather? Is it triggered by stress? Is it triggered in certain chairs, but not other chairs? Well, it hurts when I sit, but it only hurts when I sit in this chair, but not that chair. It hurts when I drive to work, but I can ride my bike without pain. So we're looking for all those details, and we're taking a detailed and caring and loving, compassionate history from people to let them know we care about them and we know that they're suffering and we really want to help. And this model can help most people. And it turned out in our study that of the traditional model, 98% of the people of those 222 had abnormalities on their MRI, 98%. When we applied these FIT criteria and the whole diagnostic approach, only 12% of the people were found to have a structural problem on their back as cause of their pain. 88% were found to have a neuroplastic condition. The vast majority of people with headaches and migraine don't have a damage in their brain. The vast majority of people with pudendal neuralgia, trigeminal neuralgia, occipital neuralgia do not have damage causing it. The vast majority of people diagnosed with small fiber neuropathy, irritable bowel syndrome, fibromyalgia, interstitial cystitis, pelvic floor dysfunction do not have structural damage to account for their pain. Every neurologist knows this about headaches, for example. 95+% headaches are called primary, which means they're not secondary to some other disease. And we're just looking more deeply and understanding how the brain works, understanding how pain is generated in the brain, and applying that knowledge to the medical knowledge of primary pain and the medical knowledge of ruling out a structural problem to call it something that we believe is reversible neuroplastic pain. That's how we do that. And it's an amazing process. And it's something we do with somebody. We try to share work on shared discovery. Why is it? Why does the pain shift and move? Why is it in this shoulder, then it's in that shoulder? Why does it, when the neck pain goes away, the lower back pain starts? Why is it that when the headaches are there, when you get a cold, I got a really bad cold and my stomach pain went away? Why is that? That's what we're doing.
That should give a lot of people a lot of hope.
I mean, that's amazing.
Yeah.
When it works right, people can feel liberated. And that hope is a big part of changing neural circuits in the brain, harnessing your own power over your brain to change them by having a diagnosis which is hopeful as opposed to a diagnosis which is soul-crushing.
Right. Yeah. So you have a book out, Unlearn Your Pain. Do you have other books too?
I have a book called Unlearn Your Anxiety and Depression. I co-wrote a book with Alan Abbas, a great psychiatrist in Halifax, Nova Scotia, called Hidden from View, which is for professionals. I work with a nonprofit group called the ATNS, Association for the Treatment of Neuroplastic Symptoms. Their website is symptomatic.me. And they have several books, textbook on psychophysiologic disorders that has 24 different authors for professionals. There's a guide to which diagnoses are more likely to be neuroplastic. We're coming out with another book on advanced treatment. So if you look at that ATNS website, then our nonprofit, it's all free. All the resources are there. There's a huge bibliography of research articles there. And people can, join us and come to our conference, our annual conference, and learn more about this work if they want to.
That's great. Thank you so much for being here with me today. I've learned a lot, and I think anybody listening has to have learned a lot. And we have a discount code, and we have your website. We've got a URL to your website to get your book there. So
yeah,
we'll put
if
that
people
on.
want, we're more than happy to help. We're doing this because we just see a need. There's a gap. There's a gap in treatment. We just started our first course for medical students at the University of Michigan. University of Michigan now has a course on using this modern pain science. So we're really excited about that as well.
That's great.
But thank you so much. Thank you for having me. I really appreciate being here.
You're welcome. Thank you.
Thanks for listening to the show. If you liked what you heard, please give us a 5-star rating or review on iTunes.